As I got another rhyme, another rhythm for y'all to listen. I'm never quitting on my mission. I'ma roll with what I'm giving. Got some ambition, this new edition, filling positions. Looking at the void in myself and feeling what's missing. Better watch the way you're going. Better go in the right direction. In the moment you're stressing, but you gon' be counting blessings. And I know that for certain. Keep on working, open curtains. Haters swerving, cause they ain't ready for your final version. I'm never gonna give up.
You're listening to the Tom Ficklin Show on WNHH LP 103.5 FM, your home for community radio.
Good morning, everyone. It's Monday, August 28th, 2023, and I kind of talk about that because we're going to talk about something called COVID-19, which most folks are somewhat familiar with, and this phrase COVID-19 entered our consciousness around 2018, 2019, and whether there will be a COVID-24 or COVID-25, the names might change, but the viral world and our kind of interacting with microbes and diseases and just remaining healthy we have to really be vigilant so that there will not be another COVID outbreak. But nonetheless, today there's some discussion in the community, and some people might know of folks as we speak this morning that have COVID. So, and the folks that even have had COVID, there's some contention and an honest observation that there might be some after effects. So we're going to really take the deep dive, and we're really pleased to have Yashira Enriquez with us and Dr. Mitsuaki Sawano to kind of share with us what's cooking in terms of this word long COVID, and not just what's cooking in your own particular kitchen, but what's developing in the scientific community, the medical community, to really help people pursue this quest of life, liberty, and the pursuit of happiness. And we're really pleased to be joined by Reverend Dr. Leroy O. Perry, pastor of St. Stephen's AME Zion Church and cultural ambassador to the Yale Clinical Research Program, and Reverend Alvin Clayton, pastor of Walters Memorial AME Zion Church and cultural ambassador to the Yale Clinical Research Program. Yashira is with us, and she's the project manager of the YCCI, Yale Center for Clinical Investigation at Yale University School of Medicine. And as I mentioned, Dr. Mitsuaki Sawano, he's a postdoctoral associate at the Center for Outcomes Research and Evaluation. Acronym is CORE, C-O-R-E. Welcome, everybody. Good morning.
Good morning.
Good morning.
Mitsu, let's jump right in. I mean, we have about 50 minutes to kind of unpack this issue, and there's so much that's on my mind, and I think on our listeners' mind and our viewers' mind about COVID and its ramifications and impact today, and as I say, it's the speculation about even in the future. So I wonder if you could give us a little update of the current prevalence of COVID-19, and are the numbers going up again?
Yeah, thanks for asking that important question on COVID, Tom. So yes, so just something to note that since the public health emergency declaration has been lifted on May 11th of this year, and reporting of COVID-19 cases or deaths have been put on hold all across the country. So the numbers that we see from CDC and other government officials, so these are COVID hospitalizations. And this is because it's a good thing, but so this is because we are no longer seeing the high rate of deaths and mortalities that we had back in 2020 or 2021. Now, we do still have numbers on COVID-related hospitalizations, and the best resource for that is that I mentioned earlier, the CDC. They have actually a very nice website that anyone can access. It's called the COVID Data Tracker. And based on that, as of August 12th of this year, earlier this month, the number of hospitalizations per week in the United States was 12,000. Now, so comparing to the peak of the pandemic, which was in January 2022, that was 120,000 hospitalizations per week. Mm-hmm. And, the second highest point was in January 2021, which was 115,000. So, subtle increase in the number of hospitalizations has been recorded in the past 5 weeks, but to put it into perspective, it's just like a tenth of what we had in those peak numbers that I mentioned earlier. Now, in New Haven County, it's the hospitalization admission rates are really at low. So it's not the entire United States that we are seeing these increases, subtle increase in hospitalizations. And even with those numbers, it's quite low as compared to those peaks that we had back in 2020 and 2021. So that's what we see as numbers.
And since Mitchell, since you've been obviously involved in focusing on this topic for, I use the word topic loosely, since you've been focusing on this critical issue about public health, and I appreciate what you've just mentioned. Is there a reason for concern? Is there a reason for concern?
Oh, is there a reason for concern, meaning upticks in hospitalizations? Yes. So in like local areas where you do see an uptick in hospitalizations, obviously there is a suspicion that the COVID virus is spreading within the community. So in those certain circumstances, you would want to take those precautions of wearing a mask, avoiding as much indoor activities as all the precautions that we have done up until 2021 or early 2022. So only in those certain areas we do want to do that, but we are not seeing, at least in numbers, serious uptick in number of deaths or rates. So I wouldn't be too alarmed to seeing these increasing numbers, but it is always nice to follow and keep a watchful eye on what is reported in these CDC websites and the news that whether or not there has been any change, since we do know that COVID do mutate and create variants. But so as far as we see in numbers, I'm not too worried about it, but it's just nice to keep an eye on it.
Perfect. And we're going to focus for the remainder on the show on long COVID, and both you and Yashira have kind of been involved with Paxlovid, and which was one of the first and currently only FDA approved oral treatments for COVID-19, and we're going to talk about long COVID and your particular research. But I appreciate your setting that context. That caution is so important. But also let's be proactive as we move forward. Reverend Clayton, Reverend Perry, I guess wanted to kind of give you a brief moment to kind of share a few comments before I go back to Mitsu and Yashira in terms of are you seeing any the impact of COVID in the community? Because whether you're been hospitalized or feeling any effects, it just seems to me it's in public. It still is in our public discussion. And as I say, I've even met 3 or 4 people last week that were not hospitalized but had the symptoms. So I just wonder, Reverend Clayton, Reverend Perry, if you had any comments about an impact might be too strong of a term, awareness of COVID and its presence, even if it's minimal in the communities that we serve. Reverend Clayton?
Yes, thanks, Tom. I've seen an increase in COVID activity, especially during the summer months when we would have various meetings, when there's a large gathering. And I've also noticed that some members will call me and tell me that I won't be in this weekend because I have COVID. It's still here, but based upon what the doctor was just telling me, I guess the deaths are down, but COVID is still, based upon what we're seeing, it's still here. I do have some good news in terms of COVID. An 86-year-old contracted COVID while on vacation. Called a physician back in Connecticut, and he prescribed Paxlovid. And she had 1.5 days that were pretty raunchy, and then almost back to normal. So that was good news. We didn't have this in 2020. So even though it's here, and the hospitalizations and deaths are down, people are still getting it, but we see that it's being worked out with masks and medications.
Excellent. Reverend Perry, good to see you as always.
Good to see you, Tom. I had a conversation with Dr. Onyema, who is a infectious disease doctor here at Yale, and I asked him about this this new spread of COVID. And he said there's a new strand, and that in the fall they're looking to have a vaccine for it. Probably around the same time they have the vaccine for the flu. He said it really wasn't. It was mild for the most part. But my question is, of the 10,000 or 12,000 people that went to the hospital, did they go to the hospital because their cases were more severe? Normally, you wouldn't go to the hospital if you got this summer COVID that's going out. It just seems to me that people who do go are people who are kept, either have comorbidities or did not take the shot, or their resistance was very low. And I think that's important to know for people who think that, it's just a common cold. It can be serious, even though it appears mild for the mass of the population. But you got to remember that mass of the population now has had some vaccine treatments. So that's my question, Dr. Mitsuaki. Give me some update on that.
Yeah, that's a great point, Reverend Perry. Obviously the COVID-19 virus is constantly mutating and creating variants, such as the most recent ones that we see are EG5 and BA2.86. These are taking more of the dominance of the major, I guess, the proportion of what we see from viral prevalence reportings. And as you mentioned, so we are seeing much lower deaths as compared to 2020 or 2021, but the virus itself has mutated in a way that is better at infecting people. So they are, yes, in numbers, I think there are more people who are being affected by the virus. And this gets to the point of long COVID as well. But, avoiding any infection in the first place is the utmost, the most important part of avoiding acute COVID complications as well as long COVID, which is caused by the virus. So, and as you mentioned, vaccinations, medications, these are going to be the important parts, especially prevention part, because, we know from the numbers from the CDC that nearly 80% of all Americans have at least received one vaccination up to now, but that will differ by communities. And getting that vaccination will help reduce that kind of like moderate to severe complications that can be caused by the virus. So those are going to be the important part as we move along the years. And even if we have the mutants variants coming in, the updated boosters vaccines will hope to help these severe cases of complications of COVID. That's what we're hoping. Yeah.
Excellent. Keep hope alive, but also keep proactive. So that's the key. And Yashira, I haven't forgotten about you. We'll come to you shortly. But Mitsu, let's take the deep dive for the remaining 40 minutes or so about long COVID. What is long COVID, And how does someone even know if they have it?
Yeah, that's a very important question. And we do believe that long COVID is perhaps like underdiagnosed or underrecognized. Long COVID is it's a wide range of new, returning, or ongoing health problems that people experience after being infected with COVID-19. Now, most people with COVID-19 will get better within a few days or within a few weeks after infection. I know I know that many. So I think you knew by experience if you had one in the previous years. But so at least 4 weeks after infection is a start when long COVID is actually diagnosed. Now, anyone who has been infected can experience long COVID. Of course, more severe cases of long COVID, severe cases of acute COVID is reported in association with higher probability of having long COVID symptoms. But it's not that only people who experience severe cases of acute COVID will have long COVID. So so anyone can have long COVID, and one of the most commonly seen symptoms from long COVID would be like brain fog, fatigue meaning tiredness, shortness of breath, inability to perform certain exercises, even though you were able to before being infected by the virus. Numbness, tingliness sensation. It's like a whole array of symptoms. So there are various symptoms associated with long COVID, and so it's generally that these symptoms that occur after that acute infection of COVID, and then you're feeling that symptom burden persisting. If that's when you suspect that when you have a long COVID case or not, and you would like to seek medical care.
And just before we go to the research project, and you're sure I'll be bringing you in, I'm just curious, Mitsu, is there a particular, what's the ballpark percentage of folks that that have COVID and the progression to long COVID? Would you say in general numbers, 20%, 30% if you've had it, that you'll have the long COVID symptoms, or is it too difficult to even speculate in that regard?
Yes. So yeah, it is difficult to estimate, but there are reports on this. So like the really conservative estimate would be around 1 in 14 adults who have been affected by the virus, but it could be 1 in 5. So it does vary, and it does depend on how you define this condition. But so roughly around 10% will be the number that we have that for now. Yeah.
And even in that delineation, is there any distinction between elderly people being affected versus for long hauler symptoms versus young people?
That's a good question. And yes, we do see that people of higher age, particularly above age 50 or 65, are highly affected by long COVID. Again, this is also reflecting their higher risk with comorbidities that I think we mentioned in our discussion earlier. So, because of weaker immune systems, they may be more susceptible to having long COVID. And viral persistence is actually one of the pathomechanisms that could be leading to these symptoms that is related to long COVID.
And yeah, sure, I'm going to bring you in a second just to kind of share with us about the the Yale PAX LC study. But Mitsu, I was just curious as we kind of wrap up this particular portion, tell us about Paxlovid and why it's being used for folks to that might have symptoms of long COVID.
Yes, so that is an important question, and that is related to our trial itself. So Paxlovid, as many of you may know, it's an oral antiviral pill that can be taken at home, and now currently is being prescribed for mild to moderate cases of acute COVID. It is a medication that came out back in 2021 as an emergency use medication, but now has been approved by the FDA, and it has been given full approval for acute COVID cases. Now, it is has been shown that it is effective of reducing hospitalizations and severe cases of acute COVID. And for this particular trial, the PAX-LC trial, we are using a 15-day regimen, which is different from what we use for acute COVID cases, which is a 5-day regimen. And the reason why we are using Paxlovid is that we believe that one of the pathomechanisms that I just mentioned earlier is what we call viral persistence within the body, meaning that COVID, the virus itself, keeps on living within our cells within the body. And then that continuously would lead to direct damage to certain organisms within our cells, or unwanted immune reactions within our body that can lead up to these long COVID symptoms. So the Paxlovid is helpful to stopping the virus to replicate itself and creating copies within our body. And that 15-day regimen, we believe, or our hypothesis is that we can stop that vicious cycle and perhaps reduce the symptom burden that we see in long COVID patients. So that's what we intend to do in our PAX-LC trial.
Excellent.
Tom, can I ask a question before we leave that?
Okay.
Are there any medications available for long COVID?
Thank you for that great question, Reverend. So the bottom line is that no, there are no evidence-based or no approved treatments for long COVID at this current moment. So that is why we are trying to seek for any medication, any agent that can help people with long COVID. And we chose this medication because as for the reasons that I stated earlier. And bottom line is that we want to help these people with an evidence-based medication.
Yashira, you have the mic. Tell us about the Yale PAX-LC study and Paxlovid.
Okay, mic check 1 2 1 2.
You got it.
So the PAX-LC study is a decentralized double-blind study that is testing the safety, efficacy, and the tolerability of Paxlovid in participants with long COVID. So let me break that down for you a little bit. Decentralized means that although the study is being conducted by Yale, participants are able to be in the study and have all study procedures done at home or at a local clinic. Is double blind, meaning that participants nor us will know who is on the active treatment or who is on the placebo. The way we are conducting the study procedures are through an array of surveys that will be sent to the participants' mobile phone or to their tablets. So no one has to come to the clinic to have blood pressure tested. We're getting all that information through a Hugo Kindred platform where participants are able to connect their medical records to this platform, and the information is pulled. So we get to see all of the visits that they've been to in the past 6 months and gather the information regarding their diagnosis, what they've been going through for their long COVID treatment.
And before we go about to ask you about the length of the study or if there's any age limit or compensation, I was just curious to share for the Paxlovid. So people take it once a day, walk me through that regimen. How's it actually used in the practice, and how's it used in the study?
So in the study, the participants are going to be taking it as prescribed, meaning twice a day. They're going to be taking 3 pills in the morning and 3 pills in the evening. The difference between how it's being used in the study versus how it's used in practice is that we're doing it for a 15-day course, and it is currently prescribed for 5 days.
Okay. And how long will the study will you be involved with this investigation?
So the study itself is 24 weeks, so it's a 15-day treatment and follow-up visits. And the follow-up visits are consistent of surveys that the participants will complete. And we're just testing, we're asking them how are they feeling, if any of their symptoms have changed, are they experiencing any adverse events or symptoms towards the medication or anything else. So we want to make sure that we gather the right information to see if the drug itself is causing any side effects and if it's being effective.
And I hear you saying it's non-invasive. So people often have this apparition about participating in a clinical trial and blood being taken, et cetera. But in this case, it's non-invasive. I mean, it's, as you say, through the mobile phone.
Aside from having blood tests drawn, so they would have three blood tests drawn at their home. And then we also are asking participants to go to a local Quest location to have safety labs drawn.
And is there any age limit?
There isn't an age limit. There is an age minimum, which is 18 years old.
Okay. And lastly, any compensation?
Yeah, so we are compensating participants for their time. They will receive $200 after the completion of the 28 visit. And the remaining $300 will be given to them at the end of the study.
And share with us, share about the number of participants that you might be looking to recruit. We often hear about, for a clinical trial, how imperative and important it is to really have full community participation. So I was just kind of curious about how many participants are you seeking to recruit?
So for this study, we are recruiting a small sample size of 100. We do wish in further studies to possibly get a larger number, but for this study, it is 100 participants that we are recruiting.
And for how long will the recruitment take place? Are you into your first year or first 6 months, or is it still just begun to embark?
Oh, well, we started enrolling in June. So I think we're going to continue recruiting until we have completely recruited the 100 participants.
Excellent. We have about 20 minutes to kind of open it up, and as you can see, we really. Excuse me. Let me mute myself. Well, I can't do that. Somebody's trying to call me back, but obviously through this show, we're trying to identify people for the study. Reverend Clayton and Reverend Perry, why is it? It sounds like a routine question, but why is it important to have communities of color represented in the study? We ask that question all the time, but I don't think we can state enough the critical imperative of our participation. Reverend Perry? Oh, he's on. Reverend Perry's on mute. Reverend Perry's on mute. Okay. Reverend Clayton? Reverend Clayton, maybe if you could start about, we mention often the imperative nature and how important it is to have people of communities of color participate in this study and other studies. So it's sometimes we think that we're repeating this too often, but I don't think we can repeat it often enough about the critical imperative of participation in studies such as this. And as we can see, it's easy to do. There's compensation, and it really has tremendous community benefit. Just wondered if you had any thoughts in that regard.
It's very important that we participate in all clinical research studies because early on, as you may know, that when the ambassadors first got involved with YCCI, there were only 3%, sometimes 6% of people of color involved in clinical research. And as we went through the training, we understood that without minority participation in studies, the medications would not work as well. in us as in other people. So even with this study, we do all we can to try to help people understand that if you participate, you're not only helping yourself, but you're helping generations to come. So that's a vital, important piece for us to make sure that we do our best to participate in research so that the medication will work better for us.
Excellent. Reverend Perry?
Yes, Tom, I think that the mere fact that COVID-19 showed the disparity in regards to minority populations and the number of deaths within our community, astronomical, that is an indication right there that we need to do more in terms of informing our community about these kind of trials if we're going to save lives and if we're going to ever keep the community that we have. One of the things I think that's significant about this particular study is that people who may be walking around with long haulers may not even be aware that there's a possibility that there can be something done about it.
Mm-hmm.
We won't know that unless we're able to get them into this study. I think that's the elephant in the room. How do we get them into the study? So Tom, this show is just one arm of how we can reach out to the community, but I think we have to develop a number of avenues to pitch this so that we can reach the populations that we need to reach. One of the significant questions that I had about this was that if the vaccine, this is just a hypothetical, y'all. If the vaccine had been boosted up in sequences so that you know that it would only last for a certain amount of days, so you boost up 60 days every 60 days, then it seems to me what you're doing now might have been done through the vaccine. That's just the question. Regardless of that, since that's a past question, the question is now, as you say, how do we deal with it? And it's really interesting because when people get COVID now, they don't give them the vaccine. They give them Paxlovid. And that's interesting because why didn't they give this to us in the beginning? Maybe y'all could answer that. But anyway, now when people go, the doctors say, how bad are your symptoms? And this is what they tell us to take. And I just think it's amazing that this drug is out there and we only find out about it in acute cases, but it just seems to me that it might have a more relevant posture here going forward.
Mitsu, I think that gauntlet was thrown somewhat in your direction. I'm not sure whether it was a fastball or a curveball, or a spitball for that matter, or a forkball. But I think you might want to have the opportunity to respond.
Thank you. So just to clarify, so Paxlovid was never intended as a preventive measure, but it's medication that is taken earlier on during an acute infection. So the earlier you take the medication, it would be better at stopping the virus to create many more copies within your body, and which could consequently develop into more severe cases of COVID. So that's the intention of this antiviral agent. The vaccinations are something different. It's totally something for prevention, which means that it has an effect of, for instance, it's like prepping your immune system towards possible future infection, so that it's like warming up your immune infection so that it won't be too overly surprised when you encounter COVID virus in the future. And yes, the boosters have been updated in a way that it warms up your immune system in a better way. And And again, this is intended to prevent severe cases of COVID or deaths due to COVID. So, and in terms of availability, the booster, I'm not sure which came out first. I know that Paxlovid was available in 2021. Vaccinations, perhaps during the same time or maybe a little bit later than that. I'm not sure. I have to look that up. But so the intentions of these two are somewhat different, and both have been shown in clinical trials that they are effective. So yeah, that's just what I would like to clarify on this. Yes. Yeah.
I can't. I have one question.
Reverend Perry, do you accept Misu's apologia and explanation?
Oh, absolutely, absolutely. I know one is for prevention, and the other one deals with after you've gotten it. But the question is, if I take the Paxlovid and a week later, am I any more or any less susceptible to COVID?
Oh, so does it have additional preventive effects?
Yeah.
That's the question. We don't actually know that. Possibly yes, but we haven't seen it. We haven't seen it in the literatures yet. Hypothetically, possibly yes, and then will we then prescribe it as a preventive measure? So that's something different. That's going to be something that you have to weigh in financial burdens of these medications. But hypothetically could be, but we just don't know at this point.
Well, will it cure the long haulers that people have? I mean, you're doing this for the study. What is the predicted hypothesis about the outcomes? Is it to cure, maintain, sustain? What is it going to do for us?
Thank you. That's a great question. So the way the trial is designed is we hypothesize that the Paxlovid in the 15-day treatment would reduce symptom burden. Symptom burden meaning we use a scale that has been validated in other research that so we would measure it when you enter this trial in the beginning, before you actually receive the Paxlovid 15-day regimen, and then we will also do the identical scale at day 28, and we would compare the differences between these scores at baseline and day 28. And that's how we would measure the effectiveness within our trial. We will also follow up until week 24. So that's also going to a secondary point where we would like to see whether or not that effectiveness is maintained throughout a longer time period. So those are the two aims that we intend to measure in our trial, and we are hoping for that we would see in long COVID patients.
And the blood draw would do what? What is the
blood draw?
Yeah.
So those are in two. There are two aims for that. One is simply to monitor any unwanted safety events, which is very unlikely to happen, but we do need it for safety reasons. The other is to explore any potential biomarkers that can be happening within participants. So similar to the symptom burden questionnaires or the surveys that we have, we will take the biospecimens at baseline and also at given time points, including in the day 14, day 28, to measure what Paxlovid had in terms of effect in the immune system. So what we do is run a various numbers of analysis which is going to be conducted at the Dr. Akiko Iwasaki's lab, and we would we would measure your immune functions throughout the trial. So that's what we intend to do with the biospecimens.
Thank you.
And Reverend Clayton, I think you had a question a few minutes ago. At least I think you were gesturing.
Dr. Perry asked the same question, so that was great. That was great.
Okay. So do you have a follow-up question, or something that just came to my mind? Let me jump in. I saw Misu, the Washington Post, had an article already out, and you were quoted, and I was so pleased to see that. And then we're always, when we do these shows, always concerned and committed to spreading the word wherever people might collect their data. Were you pleased with the Washington Post article? I was just so it seems to me it was written in a layman's word context. It also quoted you and other experts, and it just, I think, indicated how important media is, and clear and transparent media. So I was just curious from your perspective whether you were satisfied, because oftentimes people will accuse the media of manipulating or sensationalizing, et cetera. So I was just curious about since you were particularly quoted.
Tom, well, I'm not sure if I read that specific article yet, but I'm open for so social media or the media. This is I do agree that there are pros and cons, advantages, disadvantages, but we are living in a digital era, and this is part of. I think it is an important part of the scientific community as well, and it's how we spread our words, and it's just a way of how we communicate and how we yes, the proper phrasing, the proper wordings needs to be spread out there, but it's a way that we need to, especially for these kind of trials or any particular clinical research, we need to reach out to various sectors, various groups within the country, and aiming for that diversity. As we spoke earlier, the media is going to obviously have an important part in there, and we are open to. We want to put every effort to include all people from the various communities, and that's what I would like to emphasize and representing the group.
Can I follow up on that a little bit?
Yes,
please share it. Absolutely.
So I live in the Bronx, New York, which was one of the hardest hit areas with COVID-19. And doing this research, I've seen maybe 1%. Well, we have one person enrolled right now that is Hispanic or Latino. So it's really crazy to say that we don't have the diversity in the study that we need when we know that so many people suffered from COVID and are possibly suffering from long COVID. Mm-hmm. So where is the disconnect? What do we need to do to get this message out there to the individuals who are suffering and may not know that long COVID even exists, or are not properly diagnosed with long COVID by their doctor? Are they being turned away? So what is it? We need to find the answers there, so that in turn will help us diversify this trial and give aid to those people that need it.
Excellent.
I was going to say, we work with Junta, and they're going through a new change in leadership, and I think you're going to find some real good contacts there. So Junta is a part of our YCCI group. They're right here in New Haven, very popular, very strong, great history. So we're gonna make sure that we get you guys connected. The other question that I had is, do you have to go to your doctor first and have with the complaint that you think you have long haulers before you can be in this study?
Mm-hmm. Yeah, you need to be diagnosed with long COVID.
Right.
And is there a question? What's the method that your primary physician will use to believe that you're expressing your symptoms and that their symptoms are real.
Yeah.
I'll let Mitsu answer since he has the medical background, but I guess it's just the symptomatology. You go in and you say this is what you have, but your doctor needs to believe you and say, okay, this is long COVID. Right? So, Mitsu?
Yes. So so the diagnosis of long COVID would be going through the medical records that you have previously had, and also the time course, so the events or the symptoms that you have experienced throughout, or comparing to acute COVID infection, the index infection, and the post infection. And it also would be related to the previous medical histories that you may have had in the past. We do have certain sets of other conditions that can mimic or overlap with possible long COVID symptoms. So there is a certain way of differentiating or looking at those overlaps, whether to seek whether or not the current symptoms that you are suffering from right now is actually due to this virus or another condition, which could be treated for other treatments if properly diagnosed. So you do want to go through that full evaluation just to be sure that this is likely a long COVID case or not, because like I mentioned, some conditions can be treated. And so that's the thorough assessment is going to be very important.
We have about 6 more minutes, everybody. So as things kind of cross your mind in terms of sharing, please weigh in. I wanted to just mention that on Saturday we had the community health fair, the YCCI Cultural Ambassador Health Fair at Ellis Canterbury Park, and Reverend Clayton, I believe you, and I'm not sure if Reverend Perry was there. You guys were on the basketball court for a brief moment, and one of the people you're playing with is a COVID survivor. And I spoke to him after the event, and he mentioned that he felt so fatigued after just that short spell on the basketball court. So I kind of recommended that this. I told him to tune into the show, and I sent him the information over the weekend. So to Yashira's point, yeah, people don't even perhaps know that they're still suffering, and this is so key for us to kind of get the word out.
Tom, I received a phone call from a friend of mine just last week. His significant other has had COVID. Very active lady, worked every day. And after COVID, she couldn't hold a job down. No energy, brain fog. So this is real. So hopefully we can get people to participate in this study to help them. And the only way we're going to do that is just keep informing people that it's available. This show is an excellent tool to help people hear about long COVID and the other topics that we've been talking about for the last couple of years.
So one thing
Please,
Dr. Krumholz told me this morning, who is the principal investigator of the study, he said he wants this study to be the voice for long COVID patients, meaning we're making this real. We're legitimizing long COVID to all the doctors who think it's not true, and allow the diagnosis to be across all people and all communities.
Excellent. We have about 3 more minutes, everybody. I just wanted to mention your share, just as you were talking, here in New Haven, we have 30 alder people, but we also have various committees, and we also have a Black and Hispanic caucus. And I'm going to invite you and some of your colleagues, Misu, if you're available, to kind of present before the Black and Hispanic caucus, because often we'll have workshops on particular topics. And this is a topic that I'm certain that our Black and Hispanic caucus, from the aldermanic standpoint, would want to know more about. And you have the various alder representatives from the city and they can also then in turn be spokespeople for this important initiative. So stay tuned for that invitation. It's the third Wednesday of every month at City Hall, and I'll send you some information in that regard.
Okay, thank you.
Yeah, Tom, I think the other problem with our outreach is that our folk only basically go to the doctors when it's acute.
Mm-hmm.
And so, they're not going to take off time from work. They're not going to try to spend the money to go to urgent care or to try to go to the hospital, usually through emergency, because it costs too much. I mean, I wish there was a way that there was a clinic where we could forward people to, so that they could be diagnosed by a physician and just encourage them to do that. So I mean, that's what I said, when we need to look at all the avenues, because you got to look at all the disparities, and you got to look at all the reasons why folk don't know about this, why folk don't get tested. Address some of those as well as trying to get them tested. That's the hard problem. Someone's working, their mother, they got a job, they come home, they're tired. They would rather live with it than get help for it. Only time they're gonna look to get help is if it's so acute that the brain fog is so bad, the taste and smell is so prevalent that they feel like they've lost something. That's when they'll go. And once they go, how do we get them to come to you? Do they tell their doctor, I want you to contact, this long hauler study, Paxlovid? How do we do this? We got to work on those kind of details, I think, in order to make this run smoothly. And that's one of the things at YCCI that we do with our team. So, maybe we can follow up with you guys on it to come up with some ideas, some creative ideas that will help make this an expedient and relevant process. But that's what we can do.
Well, one thing that's important, if an employer has an employee who has been faithful, working throughout the years, and all of a sudden that person gets COVID, and then when they come back, they're just not the same. When a person tells them there's something wrong, people have to believe them. And even the doctors, when you have people who don't normally complain about things, but their lives are changed drastically because of long COVID. Look at a person's track record before you say, well, maybe it's not real. But we know that it is real.
It's a real good point. And it just comes to mind about reaching out to the chamber and other the business community, so they also can kind of be aware of their employee base. And yeah, we all got to kind of work together. Just before we go, everybody, we have about 1 more minute or 2 more minutes. I wanted Mitsu and Yashira to give you the last word. I give you maybe 30 seconds on, in spite of us talking about this somber reality, in one way, this should be, I think, an exciting time in terms of discovery and science and reaction and just investigation of what the future might be for life, liberty, pursuit of happiness. So I guess wondered, Yashira, maybe take 30 seconds, and Mitsu as well, about why is this indeed, it has its challenges, but is this an exciting time for you now to be in this field and to be kind of working and trying to support people and make this a better place for everyone?
It's definitely exciting for me because I feel like I'm on the ground floor helping this happen. We've been reaching out to clinics, even in my own neighborhood, reaching out to long COVID clinics, telling them about the study, because we want this to succeed and we want people to get better. So this is very exciting. We're going to continue to work hard to ensure that everyone gets the help that they need.
And Mitsu?
Yes, this is a truly exciting time to be involved in this kind of trial, and we're really we're looking forward for your participation. Having been responsible for reviewing the participants' medical record, I know people are suffering, and yes, same as Yashira mentioned, we want to help out as much as we could. So if you have any questions, please reach out to us. or the PAX LC trial website. There's a email there that you can reach out to. Yeah, and
Can you tell us that website so our listeners can hear it?
you share it.
Oh God.
I will put it in the chat so that we can put it in the comment section.
Perfect.
Okay.
Perfect.
Yale PAX
perfect.
LC study.
Excellent. Thank you, everybody. It's been a pleasure. This is a tough discussion, but a loving discussion. So I really appreciate your commitment and being a part. And we're gonna beat the drum. We're gonna create the symphony. We're gonna create the chorus. Thank you, everyone.
Thank you.
Thank you.
As I got another rhyme, another rhythm for y'all to listen. I'm never quitting on my mission. I'ma roll with what I'm giving. Got some ambition, this new edition, filling positions. Looking at the void in myself and feeling what's missing. Better watch the way you going. Better go in the right direction. In the moment you stressing, but you gon' be counting blessings. And I know that for certain. Keep on working, open curtains. Haters swerving, cause they ain't ready for your final version. Whoa. I'm never gon' give up. Fall down, I just gotta get up, yeah. Cause this is my road. Let's